Welcome, and thank you all for joining us today for this webinar with Dr. Mary Massery. We will be discussing the diaphragm and its role both as a muscle of respiration and a muscle of postural control. I'm very excited to have Mary joining us today. She received her Bachelor's of Science in Physical Therapy from Northwestern University, her Doctorate of Physical Therapy from the University of Pacific, and her Doctorate of Science from Rocky Mountain University. She has been invited to give over 1,000 professional presentations, including all 50 US states and 18 countries worldwide, on topics linking motor behaviors to breathing and postural mechanics. Mary's research pioneered the concept of managing trunk pressures as a new way to visualize core stabilization. Dr. Massery received the American Physical Therapy Association's highest award, the Florence Kendall Practice Award, for outstanding and enduring contributions to the practice of physical therapy. She has been named Outstanding Alumnus of the Year by each of her 3 universities, and she received Northwestern University's Alumni Research Achievement Award. Mary continues, in addition to all of this, to maintain a private practice in Chicago. She also continues to provide excellent CE courses, which you can check out on her website, all specializing in breathing and postural dysfunction. Mary, thank you so much for joining us. Let's get right into our first topic. Let's discuss the role of the diaphragm in respiration, both at rest and then also with activity.
It would seem like such a very small thing. And yet, when you look at the biomechanics, how it's supported in its force couplets with the surrounding muscles around it, that diaphragm is the most amazing muscle in the body. Super thin, but very large, great big parachute. I think one of the things people won't know about it is all of its different roles, that it's not just a respiratory muscle. That's so obvious that, like, why in a half an hour, why even talk about that? What's much more amazing is that the diaphragm now has 20 years of research behind it and understanding its role as a postural stabilizer. So if I have lung disease, or I had COVID and I've been in the ICU and I'm really deconditioned, that diaphragm is going to get weak very fast. And when that happens, it's going to impair the postural stabilization tools you have. What I will see as a PT is I'll see a loss of balance. Doesn't mean they're going to fall, but they might tell me I feel clumsy. I don't feel confident in my stance. I never used to hold on to the railing going up or down stairs. Now I do. All these little things that let you know that they don't have the same balance as before. And that's because the diaphragm, just like the stomach muscles, like the pelvic floor muscles, the diaphragm is part of normal postural stabilization responses.
Yeah, I think that's a great explanation to help us see that it's a whole package. It comes to, and we can briefly, but we don't stop breathing to do an activity, a prolonged activity. So we have to have the capacity to do both, or we have to prioritize. And as an SLP, I see that often in voicing. So if I have limited capacity, the same with gait, like you're saying, or balance, respiration has to take priority. It just has to. So yeah, then we start to see it in these other areas, and we so often talk about that in servicing. Well, how can I tell if there's a respiratory muscle weakness? Well, we might see it in these other areas that have to kind of give way.
And there's actually quite a number of tests that you could do to look at weakness. But before we even get into that, what I would like to point out for people is that there's that idea of surviving and thriving. You must survive. You want to thrive. I want to be an Olympic athlete with the Olympics coming up. Probably not going to happen at this stage of my life. my brain might be more focused on surviving at this point than on thriving. So when it comes to a conflict between breathing and postural control, there is no question, and this is the research that was done by Paul Hodges many years ago in 2000, and that is that the diaphragm will prioritize breathing because it must. The physiology is more important than the postural stability. That's why when someone has a respiratory condition, they have emphysema, they are post-ICU survivors, you're going to see the diaphragm focused on breathing, not on postural control. And that might mean that for you as a speech therapist, what they're saying is, I can't talk. I can't talk and walk right now at the same time because I just actually have to breathe. So I can't do that. So what I'd like people to think of is that's a measurable outcome. When you have a conflict between breathing and postural control, you're going to see that the patient's eventually going to have to hold their breath to stabilize. They can't do that for long. They can do it for several seconds. When you see that breath hold, whether it's because you wanted them to talk, or I want them to walk or climb stairs, or maybe the OT is working on upper extremity dressing, when you see that breath holding, document it. My patient can't perform the task higher than rolling over or sitting up or reaching or getting dressed or walking or the stairs. And you see where you could then progress that. So for you, you could say, they can talk as long as they're seated, but when they stand up, zip. But now they can talk while they're seated and while they're standing, but they can't talk while they walk. Now they can actually talk while they walk. You are showing a progressive change in the role of the diaphragm and the rest of the trunk muscles, not just the diaphragm, in looking at its performance as both a respiratory and a postural control muscle. So when that demand for postural stability is greater than your ability to perform that task, you go to breath hold and we get an outcome measure. Yeah. Very easy.
I love that. I love tying it with the function, and that makes a lot of sense to therapists and other clinicians. But let's hone in on the diaphragm as it contributes to postural support. So what is it doing in order to achieve postural support?
I think the easiest way to look at it is to look at the abdominal muscles. There's no question that the abdominal muscles help to stabilize the trunk. Everyone knows it. That's why they go to Pilates classes. That's why they go to yoga. That's why they do boot camps and they're going to do 1,000 crunches. But the abdominal muscles are just one part of our postural stabilization. So you've got pelvic floor, abdominal muscles. Top of that is the diaphragm. That is your abdominal cavity muscle shell. And then above that diaphragm, you have all your thoracic muscles. Of course, you have your back muscles all along, and you have your gluteus up at top. So when you look at that together, I call it the soda pop can because that's where you're going to have your pressure support. That together, that whole group of muscles, which is a lot of them, work to increase tone when there's a higher postural demand. So you're jogging. You need more support, more dynamic support. So you're going to have an increased tone in all of those muscles while they continue to play a role in whatever that task is. So let's say I'm jogging. If I'm jogging, my abdominal muscles have to constantly switch which are playing a higher role than the other in order to allow me to have counter swing, right? So that I can have rotation in my trunk and have arm swing. Diaphragm does the same thing. It's going to increase its baseline tone to meet the postural demand of increasing intra-abdominal pressure to stabilize the spine and the pelvis so that we don't fall when we run. But at the same time, that diaphragm is constantly moving. And that's why let's take jogging, for example. If you're not a very good jogger and you're jogging with somebody who's really good, they're telling you like, oh man, I can't wait to get back on an airplane. I'm going to go to Europe. I'm going to see every country. They're telling you a whole thing and they ask you, what do you want to do? And you just do this. Because you're thinking, I can't talk right now. I can't waste that air. I need all that air both for the metabolic need of running and the postural stability that I need because I'm not that efficient yet. which can be a combination of you're not efficient in your movement as well as you don't have cardiopulmonary fitness.
Yeah. And that brings right into the pressures. The soda can model really helps me. I'm very visual. So we're talking about the pressures. Yes, we're talking about muscles engaging, but the pressures also are very important. So explain that for us.
I would like people to stop thinking of core stability in terms of muscles. It's what do the muscles do that gives you stability. So what we want, all of us humans, mammals, all of us want dynamic stability so that when we stand up, we're going to use humans because it's easier than going back to the animals. So when we stand up on our 2 feet, we don't fall over. To do that, we need to increase our proximal pressures from our vocal folds down to our pelvic floor to stabilize our pelvis, our spine, our rib cage, so that our limbs can move off of that stability. And that includes the head. So when we're looking at talking, when we're looking at swallowing, when we're looking at arms, when we're looking at legs, all of that depends on our ability to generate trunk pressures, thoracic and abdominal, to be able to modulate or regulate those pressures because they're going to constantly change with both breathing as well as the task that we're doing. And we've got to be able to maintain it over time. So we've got to be able to generate, to regulate, and to maintain it. Being able to hold pressures for 1 second would be fine if all we want to do is push a heavy object or cough. So a second or two would be fine. But we can't walk. We can't carry on a conversation. We can't work in the kitchen if all we can do is maintain pressure for a second or two.
Yeah, that's very helpful. And in your soda can model, like it made so much sense when you said, is this really strong metal? Is this so strong? No, once we pop it open, we all know we can crush it. Yes, right. The pressure that's so important. And that was one of those aha moments where I was like, but of course.
That was actually, Betsy, that was my aha moment. I'm finishing up my doctoral studies at Rocky Mountain University, and our final project was this big project where we had to come up with a postural control model. And I had something else worked up, and I'm presenting it, and it's a big, big deal in terms of passing all your academics. And my colleague said, it's pretty good. I was like, oh no, it was not pretty good. It was fantastic because I'm so exhausted. You have to tell me it was nothing short of divine intervention. And they're like, no, it's pretty good, but you put the brain at the center and we don't really think you believe that. I'm like, guys, would you just stop it? And they said, but you don't. You think physiology actually rules the brain rather than the brain ruling physiology, that the brain is responding to our physiology. So the teacher said, you know what, I think that's actually really true, Mary. Why don't you go home and, think about a different model.
All that work?
I mean, I can't tell you the hundreds of hours in preparation for this big final assignment. I go home and it was like a month later. I didn't think about it at all because I was just too fried from it. My kids come home from college and they're drinking pop in the kitchen, and we had the recycle bin right there, and they're crunching it and throwing it in the recycle bin. I just went like this. I said, that's it. I left. I said, I have a dissertation to write. See you guys. And I left. I could not type fast enough as all the thoughts came through. That's what we have to do, is change our thinking from the muscles being the core stabilizers to the function of what do those muscles do. When they work together as a whole series of force couplets, none of them working by themselves, when they all work well together, they can generate that pressure so that our very flimsy rib cage, spine, and pelvis in particular, when we're looking at the core, has that dynamic stability from the muscles providing that internal pressure to be able to be generated so that we can create distal force, arms, legs, and heads. It's a whole different way from looking at it, and it really helps you understand your weak patients in particular. whether they're neurologically weak or whether they're medically weak. They're just exhausted from something. And COVID's an easy one to think of right now, with that being so much on the tip of our tongues.
Okay, so I love that you tied it all with function. And so hopefully a lot of our clinicians are thinking, okay, I can think of my patient that, falls back and when I'm trying to get them to come forward for a transfer, that kind of thing. So once we start seeing, okay, there's weakness there in the diaphragm and its role at the center of the pressure. So we have the glottis at the top and the pelvic floor at the bottom and the role of the diaphragm in the middle. What do we do to target that? Because as clinicians, it's not enough for us to diagnose or not enough for us to assess and say, oh, there's weakness. What are we going to do about it?
We have a lot more than a half hour's worth of interview there. But one thing, obviously, as I'm talking to you, Betsy, and knowing that you're with PN Medical and that you have the breather, and I don't work for you, I don't want to work for you, because I think I have a lot more credibility having absolutely nothing to gain financially from this. But all the inspiratory and expiratory muscle trainers, which are collectively called ventilatory muscle trainers, are fantastic for targeting the overall respiratory muscles. So depending on whether you're doing inspiratory resistance, you're going to get the diaphragm, you're going to get the external intercostals, you're going to get any of the muscles that can open and lift the chest, and diaphragm being the biggest player. But then you can flip it around and do the expiratory muscle trainer. So I could be the pelvic floor therapist, and I'm using it not so much for inspiration, but controlled exhalation, especially against resistance, so that I don't lose continence. So if I'm working with women postpartum, I'd love to see the breather or some other kind of expiratory muscle trainer to be part of every single postpartum rehabilitation. It should be, so that women aren't saying 5 years after giving childbirth, I've had stress incontinence ever since, but my mom said it was normal. No, it's not normal. And I think the big problem is we've always seen it as a natural process, as opposed to, yes, it's a natural process, but it's also traumatic. It's traumatic on the body, just like a surgery would be traumatic, and we need to have rehab. So for me, in order to strengthen the diaphragm and the other respiratory muscles, I love ventilatory muscle trainers. I think the breather actually is a really nice one, nice upgrade from its original model, and at a reasonable price. I'm not saying this because European Medical. I'm saying it because I say it all the time. I give it to my patients all the time. It's not just about the respiratory muscles. It's to decrease reflux forces because it reinforces the diaphragm right at the gastric junction. It's to increase lower GI motility because it gets the diaphragm to increase its inferior descent more significantly. So it helps to squeeze and release all the lower GI muscles. You might be using it because someone has congestive heart failure and you're trying to increase venous return because it's a huge, important muscle in venous return. So as well as the respiratory and the postural, that's the easiest thing to do. Doesn't always work because if it sits, I don't have one. Yes, I do. I always have one right over on my shelf next to me, and I have a blue one. So always have it right next to me. I'm not going to go over the details on how to use it. They can look at your company for how to do it. But the beauty is it's simple and can be done at home unsupervised. Great, because then my time as a therapist can be spent with higher level skill activity. The downside, it's very often sitting on the nightstand by itself, gathering dust. It doesn't work if you don't do it. It's like doing a treadmill. It's really boring, incredibly boring, but really effective.
Yeah.
So that would be one. The other thing I would do for me, I'm going to use a lot of resistance training, but when you're strengthening the respiratory muscles, you want, unless you're at a super high level of athletics, when you're in rehab, you want sub-maximal resistance. If I go to maximal resistance, my patients will breath hold because I created the conflict between breathing and postural control. Remember, they're going to do breathing or they're going to do postural control. And before they hit a conflict, all under here is submaximal. So they learn to breathe while dynamically stabilizing. So I like to use a lot of real minimal resistance where I'm putting just 2 fingers. I'm in the back. I can't quite do it to myself, but I'd be in the back, pushing the shoulders slightly back while I'm having them work on a task in front. I could be PT, OT, or speech doing that. So I'm having them come in front. I'm pulling them just with a few ounces of pressure going back. That's going to activate all your anterior flexors and your glottal muscles. So it's going to take your vocal folds and increase their tone, because the glottis is just as much of a postural stabilizer as the diaphragm. And that was my whole doctoral dissertation, which people can go to my website. You can download that from 2013. But that kind of thing is more skilled. That's what I want to spend my time on. I'm not going to spend my time doing this with the patient. I want them doing that as their home program.
That's one of my things too that I've loved about the breather. Out in the field, it takes a little time to train somebody up front, and then I'm checking in with them on it. I love my OTs because they will help make it part of the ADL routine.
Isn't that beautiful? That should give you goosebumps to see just the collaboration that we can do and should be doing all the time.
For sure.
So for me, Betsy, what I'm doing with the speech therapist is I'm saying, look, I'm going to be using voicing, because voicing is mid-range glottal control in terms of tone. So not so much tone that you have taken the vocal folds together. That's called breath hold. So that's where you go to breath hold when you're doing something very heavy, and not so floppy that you don't have enough postural stability, particularly thoracic pressures. So I talk to my speech therapist and say, look, I'm using voicing anyway. What are you working on? Are you working on consonants, vowels, phrases, full sentences, certain sounds? I can carry your goals over into the function of what I'm doing as a PT if we collaborate.
I'm going to go to, I see a few questions. The first one says, what I'm hearing is frailty, deconditioning, etc. from some condition impacts the diaphragm. Is that true? So when I get a patient back from the hospital after pneumonia, COVID, exacerbation, I should be assessing the strength of the diaphragm, correct? Also, I don't need any.
Wait, don't even go to the also. Let's do the, all right.
Saying I don't need special testing tools?
That's what I was just going to go into. You are not testing the diaphragm unless you have pulmonary function equipment. So you could be doing MIPS and MEPS, which is maximal inspiratory pressure and maximal expiratory pressure, but you do need a special device in order to measure that. And being realistic, you're probably not going to have it. I have that equipment. Why? Because my area is respiratory. So it makes sense that I have it, but the model that I have is $1,500. If I'm doing home health, I'm going to say, there's not a chance I'm going to go carry around a $1,500 piece of device and drop it at somebody's house, right? It's going to be in my clinic instead. So what you're looking at are some functional tests to be able to test not just the diaphragm. Remember, the diaphragm doesn't work by itself. It works in concerts with the other muscles around it, called force couplets. So it's going to be diaphragm in the middle, intercostals above as the primary player, diaphragm in the middle, abdominal muscles as the primary player below. But then you go all the way down to the pelvic floor and all the way up to the vocal folds, and you have all sorts of little muscles in between, including all the neck muscles and the back muscles. So what you want to look at, some real great functional things, is when do they breath hold? At what level do they breath hold? 2, how many words and or syllables can they get out in a single breath? And what is their decibel reading while doing it? Are they talking like this? Just use your phone. Everybody has a phone. Everybody has apps. So just download a decibel reader so that you have some objective measures of endurance, as well as a 6-minute or 12-minute walk test, the timed up and go. There's so many other standardized tests that you can do as well. To actually really look at the diaphragm and do the measurement directly on the function of the diaphragm, you need either needle EMGs, which none of you are doing. In fact, very few of the docs will even do it, Or this is where I really want us to get more involved, and that is ultrasound assessment of the diaphragm. And we know from research that within 12 hours of being on a ventilator, your diaphragm is wickedly deconditioned. So it very quickly deconditions, but also very quickly re-engages. So some take homes for you. If you want to strengthen the respiratory muscles, you have to demand it. You have to give some resistance. Resistance either in terms of cardiopulmonary, they're walking a little farther than they'd like, or walking a little faster. I want to hear them being a little bit short of breath, but I mean a little. If they go to breath hold too much, there's your measure. Pay attention to that breath hold. But if they're breathing, then you know they're working. So whether they're doing something like using a inspiratory or expiratory muscle trainer, the breather happens to have both on it, or whether you're doing your resistive work. So remember what I was showing you here. If I'm resisting at the shoulders while I have them doing a task coming forward, they have to activate all these muscles, which means increase tone while still making their peanut butter and jelly sandwich or doing the laundry, or if it's in pediatrics in my world, it's putting a puzzle together, but something that takes longer than 30 seconds so that they have to breathe continuously, not breath hold, while doing that task. That's increased resistance in that sub-maximal range underneath the area that has the conflict between breathing and postural control.
I'm just going to clarify. There's another question. She asked, so the pressure at the shoulders, do they do that while they're doing respiratory muscle training? And I believe what you're saying is no, while they're doing a hands-on task.
Well, they could do it either way. Do not start a COVID survivor doing resistance at the shoulder while you're doing resistance here. They will just die. Okay, way, way too hard. But if I have, let's say I have a patient who has none of that above. They are a 17-year-old high-level basketball player, great cardiovascular fitness. They fell off their bike, got hit by a car, broke their pelvis. They're not going to walk for several months. Shoot, they're going to lose all their conditioning. Guess what? I'm going to have them work inspiratory and expiratory resistance because they can't do the natural strengthening, which would be go to your basketball practice and work intensely. So most people don't need to strengthen their respiratory muscles. It happens automatically in response to increased postural demand of an activity. But if I'm now the 17-year-old 2 months in a wheelchair because I had pelvic surgery and I've got external fixators in my femur or tibia, I can use a ventilatory muscle trainer. What I would be doing as the therapist is also giving them resistance at the shoulder at the same time because they're an athlete, not an 87-year-old. And if I am giving resistance backwards, so I'm pulling them backwards just enough so they can feel their abdominal muscles engage, but then I want rotation of the trunk. So I'm going to be giving resistance on the right side and then the left side and then the right side and then the left side while I have them doing a task that requires both hands in the middle. Because when I'm walking or running, I should be able to keep my trunk stable, my head stable as I'm actually rotating. So I have rotation, but it's counter rotation. Upper body's moving in one direction, while the lower body's moving the other. And that's why when you watch the Olympics, which all PTs are obsessed with well, maybe not all, but a whole lot of us PTs are obsessed with it because it's such beautiful motor planning. And you watch those sprinters, their trunk doesn't move at all, just the limbs moving off their trunk. They're not wasting energy with their trunk going up and down. Their trunk is just going forward. It's gorgeous. I can't wait for the Olympics. The whole COVID thing's another issue, but the Olympics itself is great.
We have a couple more, and I know we're out of time. One wants to know about would doing diaphragmatic strengthening help with like swim training? And we do have quite a few athletes that use respiratory muscle training to boost performance. And so I'm going to say, go to the website and look at that. But
Well,
there are some.
I actually would like to address that, because when it first came up, ventilatory muscle trainers have been around since about 1995 or so, where they started to get more popular. And when they first started, it was actually with swimmers, that they were going to do all their regular training and they were going to do 15 to 30 minutes of inspiratory muscle training. I just rolled my eyes, like, just swim more. Just swim more and swim at a higher level, and it will demand the respiratory muscles respond. However, I was wrong, and I can admit I'm wrong. The research has shown for the highest level performers, so you're looking at NCAA Division I athletes, and they started with swimmers, they're finding that when they do inspiratory muscle training on top of their ridiculously high level of intense training, they can improve their motor performance by 1% or 2%. At that level, 1% or 2% is huge. For our patients who are at much lower level, if they, just had a total knee replacement, or they just came out of the hospital, they don't need that much resistance. Keep it submaximal, but I want you to see that range.
For sure. And again, go on the website, because you'll see that difference with Breather Fit. We do say you can go a little bit higher on effort than the medical, absolutely submaximal. And you can also go on our science blog and find research like what Mary was talking about, because we don't want you to just take our word for things.
Oh no, there's a lot of research out there.
Dig into the research.
Yeah. I will always tell people where there's research, where it's just emerging. This we actually have plenty of research on. And I was one of the skeptics. I didn't think it would be worthwhile. And it turns out at that high level, it actually is.
Yeah. We do have a few more questions, Mary, but I am aware that we're over time. So I'm going to default to you for your time if you would like to.
I have a couple more minutes, sure.
We have a couple questions about chronic fatigue or chronic pain, fibromyalgia. Where might it fit in there?
So either the breather or respiratory training?
Well, let's just talk about respiratory training in general.
Okay.
We know the breather does both.
Yeah, we know what the breather does. It's great. So if you want a barbell for the bicep, get a barbell for the bicep. This is a barbell for the respiratory muscles. But if I have chronic fatigue, you want to be really careful. And this is where you want to be careful with your COVID long haulers. The breather or something like it could be great, or it could overpower that patient. So right now with chronic fatigue, it depends on whether it's coming from a vascular perspective or an autoimmune disruption, so that the physiology of the body is not responding correctly. And in those cases, doing resistive training can actually wipe those patients out, and they can spend days having to recover. You won't know exactly, so you're going to have to tread lightly with it. So first start with something easy, like if it's somebody who can walk, can they walk across the room? And using not only your vital signs, but also perceived exertion. How hard was it for you to walk across the room? It was a 0, it was nothing. Okay, then we can probably go farther. But if they told you I walked across the room and came back and it was a 7 out of 10, their vital signs were all fine, but they're telling you about the effort. The effort it took to maintain their vital signs was way out of proportion of the task. They're not ready for resistive training. You're working at an ADL level of building up endurance. So it's a tricky one. I'm going to tell you, you really have to be careful with it, particularly the COVID long haulers. That's another area that I lecture frequently in. And that's something you want to push them this much, okay? Just this much, not this much. It's not the 17-year-old who broke his pelvis in a bicycle fall, climbing up a mountain and, riding his bike off of some crazy jump. You're looking at someone with physiologic compromise.
And then we have a question: what does the pelvic floor have to do with the diaphragm and the lungs?
Yeah,
I know you went through that. But
yeah, that's such a loaded question. It's all one shell. It's all one shell. So you've got vocal folds at the top, and that is your fine motor valve for releasing pressure. Your pelvic floor at the bottom has to come down with pressure and come back up. Diaphragm's in the center, and that's your gross motor. So think of that kind of as your leg muscles, and think of your vocal folds as your hands. So they're the fine motor regulator, just really tweaking that pressure. Diaphragm's the big mover. It's going to change pressure in both the thorax and abdomen every single phase of the respiratory cycle, which means the poor pelvic floor, which is holding all the pressure of the body, since we are bipedal, right? So we're going to stand up. All the pressure goes on that pelvic floor. If that pelvic floor can't move dynamically down and up, so in other words, it's going to come down eccentrically, come up concentrically with every breath that we take. If it can't work in that force couplet, pelvic floor, transverse abdominis, and diaphragm, that's your internal muscle shell of the abdomen, if it can't work together, then the pressure is going to leak out somewhere. Somewhere. So is that going to cause a umbilical hernia or a hiatal hernia or stress incontinence? And the easiest thing is usually where the pressure is going to go, and the easiest thing is through the pelvic floor.
Wonderful. Well, I hope we explained everyone's answers. This was brief. If you have questions, you can always keep emailing in to care@pnmedical.com, and we'll do our best. But thank you, Mary, so much.
You're welcome.
Today. What a pleasure.
Thank you, Betsy.
Yeah. You guys all have a great day.